Welcome to our in-depth exploration of cardiovascular diseases, CVD. In this new series in the channel, we will give a complete and detailed summary on common disorders of cardiac function. If you would like to review aspects about normal cardiac function, feel free to take a look on our YouTube channel, where is already a complete playlist about it. Well, remember that for this series, we are using as main source Porth's Pathophysiology book, 9th edition. Specifically, we will be focusing on Chapter 32, Disorders of Cardiac Function. In the past video, we talked about the first part of the section, Disorders of the Pericardium. We mentioned some generalities, the main classification, and we talked in detail about acute pericarditis. Definition, pathogenesis, clinical manifestations, diagnosis, treatment. In this opportunity, we are going to focus on the second part of the section, Disorders of the Pericardium. So basically, we are going to talk about pericardial effusion and cardiac tamponade. Pathogenesis, diagnosis, treatment. Let's begin. Pericardial effusion and cardiac tamponade. Pericardial effusion refers to the accumulation of fluid in the pericardial cavity, usually as a result of an inflammatory or infectious process. It may also develop as the result of neoplasms, cardiac surgery, trauma, cardiac rupture due to myocardial infarction, and dissecting aortic aneurysm. The pericardial cavity has little reserve volume. The pressure-volume relationship between the normal pericardial and cardiac volumes can be dramatically affected by only small amounts of fluid once critical levels of effusion are present. Because right heart filling pressures are lower than that of the left heart, increases in pressure are usually reflected in signs and symptoms of right-sided heart failure before equalization is achieved. Pathogenesis. The amount of fluid, the rapidity with which it accumulates, and the elasticity of the pericardium determine the effect the effusion has on cardiac function. Small pericardial effusions may produce no symptoms or abnormal clinical findings. Even a large effusion that develops slowly may cause few or no symptoms, provided the pericardium is able to stretch and avoid compressing the heart. However, a sudden accumulation of even 200 milliliters may raise intracardiac pressure to levels that seriously limit the venous return to the heart. Symptoms of cardiac compression also may occur with relatively small accumulations of fluid if the pericardium has become thickened by scar tissue or neoplastic infiltrations. It's important to keep in mind that pericardial effusion can lead to a condition called cardiac tamponade, in which there is compression of the heart due to the accumulation of fluid, pus, or blood in the pericardial sac. This life-threatening condition can be caused by infections, neoplasms, and bleeding. Cardiac tamponade results in increased intracardiac pressure, progressive limitation of ventricular diastolic filling, and reductions in stroke volume and cardiac output. The severity of the condition depends on the amount of fluid present and the rate at which it accumulates. A significant accumulation of fluid in the pericardium results in increased adrenergic stimulation, which leads to tachycardia and increased cardiac contractility. There is elevation of central venous pressure, jugular vein distension, a fall in systolic blood pressure, narrowed pulse pressure, and signs of circulatory shock. The heart sounds may become muffled because of the insulating effects of the pericardial fluid and reduced cardiac function. People with slowly developing cardiac tamponade usually appear acutely ill, but not to the extreme seen in those with rapidly developing tamponade. Diagnosis. A key diagnostic finding is pulsus paradoxus, or an exaggeration of the normal variation in the systemic arterial pulse volume with respiration. Normally, the decrease in intrathoracic pressure that occurs during inspiration accelerates venous flow, increasing right atrial and right ventricular filling. This causes the interventricular septum to bulge to the left, producing a slight decrease in left ventricular filling, stroke volume output, and systolic blood pressure. In cardiac tamponade, the left ventricle is compressed from within by movement of the interventricular septum and from without by fluid in the pericardium, as we can see in figure 32.2. This produces a marked decrease in left ventricular filling and left ventricular stroke volume output, often within a beat of the beginning of inspiration. Pulsus paradoxus can be determined by palpation, cuff sphygmomanometry, or arterial pressure monitoring. With pulsus paradoxus, the arterial pulse as palpated at the carotid or femoral artery becomes weakened or absent during inspiration and becomes stronger during expiration. Palpation provides only a gross estimate of the degree of pulsus paradoxus. It is more sensitively estimated when the blood pressure cuff is used to compare the carot cough sounds during inspiration and expiration. A decline in systolic pressure greater than 10 millimeters of mercury during inspiration is suggestive of tamponade. Arterial pressure monitoring allows visualization of the arterial pressure waveform and measurement of the blood pressure drop during inspiration. The echocardiogram is a rapid, accurate, and widely used method of evaluating pericardial effusion. The ECG often reveals nonspecific T-wave changes and low QRS voltage. Usually only moderate to large effusions can be detected by chest radiography. Treatment of pericardial effusions depends on the progression to cardiac tamponade. In small pericardial effusions or mild cardiac tamponade, NSAIDs, colchicine, or corticosteroids may minimize fluid accumulation. Pericardiocentesis, or removal of fluid from the pericardial sac, often with the aid of echocardiography, is the initial treatment of choice. Closed pericardiocentesis, which is performed with a needle inserted through the chest wall, may be an emergency life-saving measure in severe cardiac tamponade. Open pericardiocentesis may be used for recurrent or loculated effusions, that is, those confined to one or more pockets in the pleural space, during which biopsies can be obtained and pericardial windows created. Aspiration and laboratory evaluation of the pericardial fluid may be used to identify the causative agent. Thank you so much. This is all for this part. In the last part of disorders of the pericardium, we will cover constrictive pericarditis, etiology and clinical manifestations and diagnosis. If you found the content useful, don't forget to like the video and subscribe to keep track of all our content.